Hello, good afternoon, and welcome back to the 19th Indoanesthesia Symposium. So I hope everyone's already have a good lunch since we still have another half day to go. For this session, we're going to discuss something that's quite interesting. We're going to discuss about the role of TIVA or TCI in enhanced recovery. I know this must be very intriguing for some people who I know in Indonesia is enhanced recovery protocol is quite famous now. So we're going to listen the presentation from Professor Michael Irwin from Hong Kong. And for this session will be led by Dr. Aino Nindya Arkari from Indonesia. I also want to thank PT Mindray Indonesia for sponsoring this symposium. Okay, please, Dr. Aino.
Thank you, Dr. Krisha. Thank you for having me. We are just a little bit past lunchtime here in Indonesia, and we are very happy to have Professor Michael Irwin from Hong Kong joining us. Good afternoon, sir.
Good afternoon. Thank you, Lena.
Hi.
Nice to be here.
Thank you for coming. We are very delighted to be hearing of your talk this noon. While you prepare, you can start trying to share your screen if you would like to try. We are very happy to have you here all the way from Hong Kong. And I believe that many of your research work is focused on total intravenous anesthesia, which is our topic this afternoon. We're going to talk about its use for ERAS. By all means, you can have the time now. The time is yours, Professor Irwin.
Thank you very much, Dr. Leno. So, yeah, I think this is obviously a very pertinent topic. The whole concept of perioperative medicine and enhanced recovery is gaining a lot of traction in our specialty, and I think quite rightly so, because it's very important for us as a specialty to start to take charge of these areas, not just the management of patients intraoperatively, but getting patients optimally prepared for surgery, and then managing the whole post-op course. Especially now, we're dealing with more and more elderly, difficult patients, frailure patients, etc. So I think most of you should be fairly familiar. This is picture was taken, as you can see, some time ago, because I still had some hair at that time, when I had knee surgery. And it was actually just about maybe around an hour after the surgery had finished. And you can see that I was just ignoring the NPO sign in the background, having a cup of coffee and a banana. So I was myself had tried to be a pioneer of enhanced recovery. Now, just quickly, I just give a few disclosures because we just want to get that out there. I don't have any relationship with any pharmaceutical company, although the talk is actually sponsored by Mindray. I'm not getting paid for that. They are sponsoring the session through Anesthesia. Now, early recovery after surgery is one of the facets of evidence-based perioperative medicine, and it's meant to improve the quality of care, and by doing so, improve the value of our surgical procedures. So that value can be defined by quality over cost. There may be some initial increase in costs required in order to initiate these kind of programs and so on. But once they've got going, it's been shown quite clearly that they can reduce, in fact, significantly reduce costs by reducing length of stay and reducing complications in patients. So what I'm going to talk about is the kind of anesthetic component of that. Enhanced recovery is not a recipe for care. It's a concept that involves not just intraoperative care, but as I said before, preoperative and postoperative. But we're going to focus more on the intraoperative aspect here in relation to the anesthesia. So I think for anesthesia, what's going to be important for us is we need a technique which is very titratable. We need something which we can control the depth of anesthesia very easily, so we can get a quick and, importantly, a smooth recovery. It's not just about the speed of recovery. You can get a fast recovery with some modern inhalational drugs like desferrine, for example, but it's not necessarily smooth. Patients may wake up with more delirium, more side effects. So quality is really more important than speed. So with a propofol-based technique, you can get a pretty quick recovery. It's also very smooth. We want to minimize the side effects of anesthesia on the patient, and that, obviously primarily be things like nausea, vomiting, pain. We don't want to impair ambulation. So that actually has some implications in terms of certain types of nerve blocks. I think, for example, in surgery, knee surgery, it's kind of a move away from doing, say, femoral blocks and so on towards things like adductor canal blocks, and maybe even avoiding blocks altogether, because we know it's important to get patients up and walking quickly. We don't want patients to have delirium. We don't want to have cognitive impairment, and avoiding excessively deep anesthesia appears to be quite important in regards to some of those aspects. Now, there's a whole host of general anesthetic drugs that we could use, and sometimes, we could think of anesthesia, but like cooking, you have different ingredients that you can put in to try and bake the nicest possible dish. So we have, classical drugs, inhalational drugs. Now there are newer generation inhalational drugs like sevoflurane and desflurane. Essentially, have pretty much superseded drugs like isoflurane. I think very few people using that, and halothane, although halothane is still used in some countries. And now we have better technology in terms of infusion pumps, particularly target-controlled infusion, as you can see here with this Mindray pump. We were able to give drugs like propofol. We've always been able to give them, but now with using, as I'll explain in a few minutes, using target-controlled infusion, we can do this very accurately and quite easily. So intravenous anesthesia is not just propofol. Propofol tends to be the mainstay drug that produces the loss of consciousness, but we will have to give that along with analgesics, usually short-acting opioids, sometimes using adjuvant drugs such as dexmedetomidine, which is an alpha-2 agonist. Ketamine can be very useful, particularly for bigger and more painful surgeries. And benzodiazepines I put in, but mainly because benzodiazepines are available, but I would suggest avoiding benzodiazepines if you possibly can, because they're associated with impaired cognition and delayed recovery after surgery. So although they are an intravenous drug, then they're not one that we would have in our typical TIVA armamentarium. With gases, there are also the option of using other drugs like nitrous oxide. Sometimes I would refer to nitrous oxide as a bit like, I don't know if you ever watched the old spaghetti westerns, but the good, the bad, and the ugly, because it does have some good effects. It's fairly easy to produce and cheap, and it is an NMDA antagonist similar to ketamine, which may prevent enhancement of pain sensitivity and help improve postoperative analgesia. But unfortunately, it does have potent emetic effects. There's differential pressure effects, which can affect the bowel, middle ear, and eye. In fact, there are even reports of patients being blinded as a result of nitrous oxide effects on the eye in eye surgery. So definitely want to avoid it in ophthalmic cases. It increases intracranial pressure, and as we are getting more and more concerned now with the environment, it has quite bad effects on the environment. Then it just has plain ugly effects, which related to its effects on methionine synthesis, increasing vitamin B12 function, depressing bone marrow, reducing reproductive health, and possibly reducing neurotoxicity. This is certainly known very clearly with more long-term use, or certainly higher doses, maybe less so in short surgical procedures, but there's no doubt that it doesn't do patients any good. So what I would classify total intravenous anesthesia is really avoiding inhalation anesthetics, using propofol as your hypnotic, generally using opioid analgesics, unless you can do something like a regional block or something like this, perhaps epidural or other types of blocks, plus or minus adjuvant drugs such as ketamine and dexmedetomidine. So that's my idea of TIVA. The advantages are fairly clear, and I'm sure you're pretty familiar with that. We've mentioned the recovery benefits, the titratability of the drug, its lack of environmental impact. Also remember that these inhalation drugs are very difficult to avoid pollution personally to you and to your colleagues in the operating theatres and the recovery room. And again, that's not a problem when you're using TIVA. Propofol reduces intracranial pressure, reduces oxygen consumption in the brain, which has benefits, reduces nausea and vomiting. It's much better for neurophysiological monitoring. It can be used in low doses for sedation. It doesn't reduce hypoxic vasoconstriction in the lungs. So if you're doing pulmonary surgery and one lung ventilation, it's better. Possibly less neurotoxicity and interestingly, less postoperative pain. Now, some of these things are non-anesthetic properties, and these non-anesthetic properties can be specific to propofol, so things like anti-mesis, free radical scavenging, neuroprotection, and so on, but also by avoiding inhalational anesthetic drugs, you're getting some benefits like in environmental pollution and so on. So the manufacturers of sevoflurane kind of hit back at this concept of TIVA because they came up with this idea of VIMA, which was a volatile induction and maintenance of anesthesia. But I think you'll find not many patients these days will like to have an inhalational induction of anesthesia, and it's really quite unnecessary to do so. So I refer to VIMA as a vomit-inducing method of anesthesia. And I think given the choice as a patient, just like you saw there, I've been a patient myself a few times, I absolutely insist on propofol. And what I think is best for me, I think is best, obviously, for my patients. Now, the antiemetic effects are actually multimodal. It has an interaction with dopamine receptors, but also on 5-HT3. And if you want to use propofol to reduce PONV, it's not good enough just to use it for induction. You really have to use it for both induction and maintenance. You don't see this benefit if you're just using it for induction. Now, the immune system effects are actually very interesting because there's been a lot of excitement about this in recent years in relation to, the effects of surgery and so on immune function. Propofol resembles one of the vitamin E analogs, which is an antioxidant called alpha tocopherol. It's structurally very similar to that, and it has very strong anti-inflammatory effects. It inhibits production of certain pro-inflammatory cytokines, but it doesn't have any effect on natural killer cell function. This is important because natural killer cells seem to be important in things like killing metastatic cancer cells or circulating tumor cells, which can be released during cancer surgery. We had a look at the issue of, because a number of studies have actually now looked at whether propofol induction and maintenance is associated with less pain after surgery. So we did a systematic review of meta-analysis and found that propofol does reduce postoperative pain compared with inhalation anesthesia, and this is seen even 24 hours after surgery. Obviously, there's a lower incidence of nausea and vomiting as well, and that has been known already quite well. The effect is, although present, it's not, I wouldn't say it's a very powerful effect. I would say it's quite a reasonably modest effect. But when you're trying to manage and reduce pain, I think anything you can do to reduce pain after surgery is going to be a potential benefit. The reasons for this are quite clear when you look at mechanistic reasons for propofol having this analgesic effect. I think probably related to its anti-inflammatory effects, its modulation of GABA and glycine receptors, and it also inhibits these pacemaker channels called HCN channels. There are 4 of these channels present in your body. Some of them are important for, I think HCN4 is important for cardiac pacemaker, and propofol doesn't have any effect on that channel. It just has an effect on the HCN1 channels. And HCN1 channels are excitability and firing is increased when there's any damage to the peripheral nervous system. And in fact, that damage to the peripheral nervous system is inevitable with any type of surgery, which is breaching the skin and body cavities. So it's almost impossible to avoid. And it's interesting that propofol can inhibit this this effect and may be an anti-hyperalgesic target for damaged peripheral nervous system. And that is thought to be associated with the development of chronic and neuropathic pain. So that's why propofol may have some benefits also in that regard. In fact, it's been shown that propofol infusion can actually completely remove certain types of neuropathic pain in some patients. But the other aspect of the effects of propofol intraoperatively in certain types of surgery is in cancer, because many patients, probably around 80% of patients with cancer, will require some form of surgery. And it's very important for them not just to have well-performed surgery, but to have a good recovery. Now, the issue of having surgery with cancer could be described as a kind of a perfect storm for cancer recurrence and metastasis. I gave a lecture about this last week, actually. I don't know if you watched it, but just to quickly summarize, it's been known about for a long time that surgery can actually make cancer worse in terms of even though you're moving the primary tumor, etc., metastatic problems can occur and so on. We know that circulating tumor cells are released in many types of surgery. We ourselves have been doing some research on that with hepatic surgery and hepatocellular carcinoma. You can see here that there are issues like surgical stress, angiogenesis, immunosuppression, inflammation, all of these creating this perfect storm for cancer recurrence and metastasis. And propofol may well have the benefits which can negate some of these adverse effects, because it displays quite useful anti-tumour properties, both in cell cultures and in living organisms in laboratory settings. So this has been shown in laboratory settings. There are ongoing studies in humans. There's some retrospective work, which I'll show you in a minute. It also enhances cytotoxic T lymphocyte activity. This is important for killing these tumor cells. It inhibits cyclooxygenase. We also have other drugs like non-steroidals that do that. They may well also be beneficial in patients with cancer. And it inhibits hypoxia-inducible factor, which is one of the downstream mediators which helps to activate cancer cells in metastasis. So this inhibitory effect could well be beneficial. So there's good basic science data, but fairly limited good clinical data, much of which is retrospective. As you can see, I've shown a few studies here. Sorry, we'll go back to this. The biggest one was the study done by Tim Whitmore and his colleagues at the Royal Marsden Hospital in London, which is a very big cancer centre in the UK. Now they just do cancer surgery, and they're also very interested in TIVA. So many of their patients had received intravenous anaesthesia as part of their anaesthesia, and so they decided to look to see if there was any difference. So they did a retrospective analysis of about 7,000 patients who were propensity matched to volatile or TIVA, and then they looked at their outcomes over a period of 5 years. They found that the mortality was 50% higher with the volatile intravenous anesthesia than with intravenous. I mean, this is actually incredible. If you came up with a drug which had that effect, it would be an absolute blockbuster. Who wouldn't pay anything to have that kind of benefit when they were having cancer surgery? So it's huge effect on the weight. And you can see that here in this Kaplan-Meier survival curve, the difference. The difference in mortality and survival was independent of ASA status of the patients. And as I say, it was propensity matched. Now, the problem, of course, is that it's retrospective. And with retrospective data, you can never be sure that there may be some other confounding factor which is influencing the results. So it's very important for this type of study to be repeated prospectively. And there are a number of trials ongoing prospectively to look at this. We don't have any results of those yet. I just show you here the problem with retrospective data. It could be that there is a problem with inhalation anesthetics, that they are having a negative effect, and that propofol has no effect. It's just that it doesn't have this negative effect. Propofol could have this beneficial effect, or it could be a combination of both. Or as I say, it could be some other unknown factor that we're not yet aware of. So we can only find that with prospective randomized controlled trial. Now, again, when we're talking about cancer, we're not it's not just the intraoperative issue that's important. It's getting these patients back to their normal activity. And I was just watching Cecile's band. They're playing Mustang Sally and so on at the during the interval. Fantastic stuff. And there's a band called the Kaiser Chiefs. They may know them. They had a kind of famous song called I Predict a Riot. Now, Riot is an acronym, in fact, not by them, but by doctors for Return to Intended Oncological Therapy. It's a novel quality indicator because it can show when patients, maybe rephrase that, patients who are having cancer surgery is only one aspect of their treatments, and they may need other adjuvant treatments like radiotherapy, chemotherapy, and they won't be able to get these treatments until they're basically fit enough and feeling well enough to undergo them. If they are having problems with recovering from surgery, that's going to delay their ability to get back to normal activity, to get adequate nutrition, to be in a good physical state in order to undergo other adjuvant therapies. So we don't want patients with pain, PONV, impaired mobility, etc., and things like deep vein thrombosis. These things all can delay recovery. So using a TIVA-based technique is likely to be able to get your patients back to this normal activity more quickly. Propofol plays an important role in multimodal neuroprotection. So if those of you who do neurosurgery or neuroanesthesia, I think you'll find that most neuroanesthetists will use Propofol as their go-to anesthesia technique. It's a kind of global thing. It's a very, very well established now. Now, sometimes one of the ways I like to look at the clinical manifestations of anesthetic toxicity is to divide them into two groups. Now, it's not quite right because they're not entirely distinct groups, but clinically they are a little bit distinct. And so I think it makes it a bit easier to understand if you break it down like this. Emergence, delirium, and psychosis is something that can occur very easily and very quickly after patients wake up from their anesthesia. It's not just that they may be hyperactive, but also you can get hypoactive delirium. Patients who are very quiet, withdrawn. These patients often have confusional states. They often get a bit neglected actually in post-op because people worry more about the hyperactivity delirium. And so these sort of psychotic effects tend to occur quite quickly. Fortunately, they're fairly limited, can last just maybe hours or maybe a couple of days, and likely not to have too much in the way of long-term effects. Now, the reason I divide it is because this emergence delirium psychosis seems to be quite closely related to the type of anesthesia that you use, whether it's, using benzodiazepines, using inhalational drugs versus propofol. Whereas the postoperative cognitive dysfunction is very much a multimodal type of phenomenon, and it can occur even in patients who don't have general anesthesia. It can occur after regional anesthesia techniques. It's much more complex. There's a lot of work going into this. The anesthetic drugs may have some impact on this, but it's not as marked probably as things like emergence delirium. This looks a little bit complicated, but if we try to break it down a little bit, you can see why there may be a difference with the different types of anesthetics. So if we look at inhalational anesthetics do have some neuroprotective effects here. You can see inhibition of cerebral metabolic rates, activation of GABA receptors, inhibiting glutamate, and so on. But they also have undesirable, potentially neurotoxic effects, enhancing A-beta polymerization. This is something that occurs as a prelude to the amyloid plaques that grow in patients with Alzheimer's disease. And you can see this imbalance of cell excitement inhibition, activating neural cell death, activating these intrinsic pathways of apoptosis. Now, propofol also can have neurotoxic effects. It's not, I don't like to give a lecture which is totally, I may have a bias, of course, because I'm, a big proponent of TIVA, but I do appreciate that anesthetics are not perfect. But propofol seems to have the balance more towards the neuroprotective effect, and tend to only see this neurotoxicity in higher doses, which is why it's important to manage your depth of anesthesia very carefully during surgery, irrespective of whether you're using TIVA or an inhalational technique. Emergence delirium occurs differentially with different drugs, and even with inhalational drugs, it's much more common with sevoflurane than it is, for example, with desflurane. In fact, it's been shown in children and after sevoflurane that kind of obvious consequences. I was asked to look at a case which occurred actually in the United States some years back, about 5 or 6 years ago. It was actually a Hong Kong woman, a Hong Kong French woman who went to California for plastic surgery, and she underwent a 12-hour procedure with what I can only describe as a really terrible anesthetic technique, using benzodiazepines, some sevoflurane, very poor analgesia, and this lady developed an acute confusional state immediately after the surgery, was talking to herself, had never exhibited any psychosis ever in her life before, and somehow, this is another issue, I can't discuss it in detail, but she somehow managed to get from the post-anesthesia recovery room up to the roof of the hospital, and they even got her husband, tried to talk her down, and she unfortunately jumped off the roof of the hospital, committed suicide. So this is an extreme example of post-op delirium. I'm not blaming anything to do with drugs or whatever. Her anesthetic technique was certainly not one which I would have used. I'm sure a lot of you wouldn't. But it's just to illustrate that it's not always a relatively benign thing. It can be extremely serious. Now, there's a science called Metabolomics. I don't know if you've ever heard of this, but it's a way to look at the cellular events that are occurring in an organ by measuring the products of metabolism. And it can be done in real time with proton magnetic resonance spectroscopy. It can be done for the brain as well. And it's been shown that the metabolomic signatures are different with sevoflurane versus propofol. Propofol tends to have higher lactate and higher glucose. And these brain glucose and lactate concentrations correlate very strongly with emergence delirium. So it's one of the reasons why different drugs may have differential effects and causing emergence delirium. There are some limited data looking at this. This is a Cochrane systematic review, which looked at the issue of intravenous versus inhalational maintenance or postoperative cognitive function or outcomes in elderly people. And I'll just show you their kind of main conclusion. They say we are uncertain whether maintenance with propofol-based TIVA or with inhalation agents affect incidence of postoperative delirium, mortality, or length of hospital stay because certainty of evidence was low. They did find low certainty evidence that maintenance with propofol may reduce postoperative cognitive dysfunction, but they weren't able to form meta-analysis on that because of what they call heterogeneity between studies. And this is always a problem with meta-analyses because the studies are all different. It's very difficult to put them all together. But so basically what they're saying is there was some tendency that propofol has a benefit, but it wasn't easy to make a very clear distinction. This is another couple of studies which were generally supportive of propofol improving post-op cognition in patients. Either in one case was lung cancer resection, and the other one was just a general surgery. So both of these showed some benefit. You can see that in the first one, the benefit is not huge, but there is a benefit there. And I think this is important because every little thing you can do certainly helps. Now, I mentioned this pretty simple study that we did a few years back, just because I want to illustrate that that even irrespective of what anesthesia you use, it's not necessary to have very deep anesthesia. Now, one of the benefits, I think, of TIVA is having this differential effects. So you basically have a drug, Propofol, which can be used to render your patient unconscious, and you only need to give enough Propofol to get the patient unconscious. When you want to attenuate the stress of surgery, you use something else. You use an analgesic, in this case, remifentanil. You don't use high doses of Propofol to do that. It is completely unnecessary, and as we saw earlier, it may be harmful. Now, this study was very simple because what we did was we had several groups, two groups of patients. One group of patients was given a target-controlled infusion of remifentanil and a fairly modest dose. It was 3 nanograms per mil, so it's enough to provide analgesia without having a very marked suppression of respiration. There was some suppression of respiration, and actually in a few patients, we needed to bag them a little bit. So we did that, and then we start the Propofol target-controlled infusion, and we stepped up the Propofol target-controlled infusion, firstly until the patients lost consciousness. And you can see here in the first part of the slide, the red and the blue, that when patients didn't have any remifentanil, they needed around 3 mics per mil of Propofol to make them unconscious. So this is just like, they just stop responding to commands, they drop the syringe, they light stimulation, they wouldn't respond. If they were getting a concurrent infusion of remifentanil, the concentration of Propofol, the requirement was reduced a little bit. You can see it's not a lot. It was gone down from about 3 to about 2.5, something like that. It's not a big difference. Now, where you're seeing the big difference was we then gave the patients a painful stimulus, which was tetanic stimulus to the ulnar nerve, which is safe and repeatable. And then we would then see whether the patient would withdraw their limb or flex or extend, and we would then increase the Propofol until the point where they would no longer exhibit pain. If we weren't giving them remifentanil, we had to give the Propofol really high concentration, up to about 4.5 to 5.5, to stop patient moving to pain. But when you're giving remifentanil, we hardly had to give any more Propofol at all. So it's really just an illustration that analgesia should be provided by analgesics, not hypnotics, and we can do that with TIVA. Now, monitoring depth of anesthesia may also help to reduce post-op delirium, as I say. So that, again, has been shown with things like BIS. If the BIS level or the EEG suppression is too high, then patients are more likely to develop post-operative cognitive dysfunction. There are other issues that you need to be concerned about as well, like excessive or prolonged hypotension, certainly cerebral desaturation, and so on. If you're interested in this field, because I don't have time to go into it in this lecture, my colleagues and I just wrote a review article about this very topic of perioperative neurological monitoring, because I think it's an increasingly important field, and it's very important to understand the concept of EEG monitoring, not just looking at a BIS number or a Z-line number or whatever. There's much more to the EEG than just this number, and these numbers can actually be very unreliable. So just take a couple of hours, read an article like this, learn how to interpret the EEG, just like you can interpret an ECG. It's not difficult at all. This is a free download from the Journal of Anesthesia. You just go to the Anesthesia website and you can get the supplement for free. There are also lots of other devices we use to help with enhanced recovery, to avoid excessive instrumentation of the airway by using things like supraglottic airway devices. And they have obviously certain advantages over intratracheal intubation. As you can see here, they're easy to put in. You don't need the laryngoscope, you less likely to cough and buck and so on. You don't need muscle relaxants. They preserve laryngeal competence, less trauma. And the insertion and ease of use is very easy with TIVA. TIVA and supraglottic airway devices actually kind of go together. Very difficult to put them in without propofol. In UK, there's a national audit project which is conducted by the Royal College of Anaesthetics every year. It's a fantastic project. I urge you all to read the national audit projects. They are now on number 7. This is number 5. This one actually was to look at accidental awareness during general anaesthesia. Now, one of the things that came out of it was the TIVA use in the UK and Ireland was actually very low. This is a couple of years ago, or actually it's more than a few years ago, it's about 5-6 years ago. TIVA use at that time was only less than 1 in 10 patients were getting total intravenous anesthesia. Now, this kind of spurred us to wonder why this is. And so we did a survey around the time of the World Congress of Anesthesia in Hong Kong to look at this. And it was interesting because one of the factors that people sometimes said was they thought it was more expensive than inhalation anesthesia. So we published the paper in Anesthesia and Intensive Care and did all this. And then these two guys wrote in and they did a cost comparison between TIVA and inhalational anesthesia. They looked at both sevoflurane and desflurane and then propofol, and with standard techniques and also taking into consideration the cost of the syringes and all the ancillary equipment that's required, etc. They found that desflurane was about 10 times more expensive than TIVA, and that's a huge difference. And that sevoflurane was comparable to the cost of TIVA only if you were using very low fresh gas flows and only if it was intermediate duration surgery. If not, then it was actually more expensive than propofol. So this is not any special technique. This is not an expensive technique. This is a technique available for everyone. The other issue that came up with often with TIVA was the TCI problem. The TCI limitations were that there were various different models available, and this would be quite confusing. It's not available in some countries. People worried, how do you use it in children? How do you use it in elderly patients? How do you use it in patients who are obese, got a high BMI, and so on? And so some people would wittily refer to TCI as a totally confused infusion. However, now we have a new model, which is called the Eleveld PK model. I really think this is quite a game changer for TIVA because it's a very good, what we call general purpose model. It can be used in any type of patient, thin, fat, tall, short, young or old. And essentially the pump, you just put in the patient's physiological data, and the pump will choose the most appropriate PK model to use for that individual. So there's no need for you to select a Schneider model or a Marsh model or whatever. It'll all done for you. So this really takes away a lot of this confusion, I think. And it has, as I say, allometric scaling and everything. Retrospective analysis suggests that it performs very well. I've had the opportunity to use it in another type of pump, and I find it to be very good. And I believe it will be available in the Mindray TCI pumps later this year, along with other TCI models like for dexmedetomidine. So just to give a shout out to Mindray, as I say, I have no personal association, but I know that they are sponsoring this session, which is very kind, and help the Indo-Anesthesia Society. So give them a shout out for the pumps. So here's a picture and show you that they do have a variety of models available, and they will have the Eleveld available later. The pumps, I've not actually had a chance to use them myself, but they seem to be pretty good versatile pumps. There's also the possibility in the future of monitoring propofol in the expired air. There is technology available to do that, but it's not commercially available at the moment. So let's finish up here just by talking about this ARS. When we look at ARS, one of the ways that we look at it is by using a thing called an ARS wheel. Again, it's something I'm sure you've seen. And the Ayres wheel is just showing this kind of multimodal way of managing enhanced recovery. Enhanced recovery is not just an anesthesia thing. It involves nursing care, surgical care, physiotherapists, nutrition, dietitians, you name it, okay? It's a multimodal, truly multimodal type of patient care. And there are whole different facets, as you can see here, for Ayres. Now, if we put TIVA into this, you'll see that TIVA affects quite a few of these aspects of the wheel. And that's why I think TIVA has an important role in enhanced recovery after surgery. If you're interested in learning more, I just give you a couple more articles which I've written, or not. I didn't write the first one. It's guidelines from the UK SIVA, and I wrote an editorial about that. And I've written a textbook which is called Taking on TIVA, which is a way of kind of making TIVA more easy to understand and to perhaps learn how to do it. Also, a colleague of mine and I have just setting up a website in a system called FutureLearn, which will be a free learning resource for how to learn how to do TIVA online. So we can let you know about that whenever it becomes functional. Thank you very much indeed. That's it.
Thank you very much. Thank you very much, Professor Irwin. That was an excellent review on conducting TIVA. I think I would like to start with a very broad question, which would be a great introduction to our discussion. Do you use TCI TIVA? Hello, do you use TCI TIVA?
Hello.
Hi.
Sorry, the door is not locked. My wife,
all right. You can join
There's
us.
another one here.
Is that your
Yeah,
daughters?
my daughters, yeah. So
Hello.
yeah. You can wait for this picture.
Hi.
Okay. You can wait as well.
Hi.
Yeah. Okay.
This was this the one in your picture?
No,
you had the
that's
surgery?
my older daughter. No, she's the older one. These are just the two young ones. Yeah, complicated.
All right. That was nice of them to join us this afternoon. I think we can start with the discussion on, given your extensive experience with TIVA, on what kind of patients do you use them? Do you pick them out on specific populations, or do you have like some population that will benefit most for TIVA?
Yeah. So for me personally, honestly, I don't use anything else. I never use inhalational anesthesia. The only time I ever use it is I do some work in a hospital in Cambodia, which I haven't been able to go to for the last couple of years. And we obviously there we don't have the pumps and it's difficult to get certain drugs. So we use halothane mostly. But I don't think there's any special population in whom you need to give it. I guess there are some patients who may benefit more than others. The patient, say, gives you a history of having postoperative nausea and vomiting, or they're having a certain type of surgery where there's more likely to have nausea and vomiting. So, for example, gynecological surgery, breast surgery, these are often, as you know, strongly associated. I think also with that quite interesting data on cancer, I would strongly recommend that patients having cancer surgery, it's something to think about. I mean, I wanted to emphasize that the data is retrospective data. It's not, it's not entirely proven, but there are certainly a lot of reasons why it may well be very beneficial to patients who are having cancer surgery. So they maybe have a stronger indication. Yes.
Okay, it's interesting to learn that you almost always conduct TIVA in all patients. Do you have a specific regimen that you tend to prefer? Is it Propofol fentanyl or propofol with fentanyl, or what is your usual regimen?
Yeah, so we have remifentanil here, and we don't have sufentanil. Sufentanil is fine. Alfentanil is fine as well. I used to use alfentanil before Remi came along. Remi obviously has some benefits because it's a very fast onset, fast offset, very titratable. As I showed in that little study that we did with the 4 different colored bars, I think it's a very important adjuvant in TIVA because it allows you to minimize your use of propofol. And in fact, even if you're using inhalational anesthesia, it also allows you to reduce your dose of inhalational anesthesia because we know that excessively deep anesthesia is not good for patients. So that's a good reason to use it. And I would generally I would say almost always use remifentanil unless I was doing something like an epidural. And even then, I would probably use a very low dose just so they can tolerate the tube. But to give longer acting opioid or some other analgesic to attenuate the pain after surgery. So I put in IV. I would then start the propofol at around 1 micromil because then the patient just relaxes, right, gets much more calm, more comfortable. They'll start chatting to you and so on. Their anxiety all goes away, and then I can pre-oxygenate them, and then I'll basically step up the infusion and that in the Remi. That's the standard way I would do it.
Okay. On this note, do you use like a designated IV line for your TCI? Or do you mix them with your?
Well, that's a very good question as well. I think if you have one-way valves, then you don't need to use a dedicated line. You can put it in your intravenous and fluid infusion line as close to the patient as possible, even this little short extension. Don't big big dead space, that's obviously not good. But it's very important to have a one-way valve because you have to give the TIVA.
Absolutely essential that we would have this EEG or
important to remember that the instance of awareness was really less than 1 in 10,000 or 50, something. And so when you double something which is very, very small, it doesn't mean that the risk is really, really high.
Okay.
And interestingly, paradoxically, actually, believe it or not, the instance of awareness was higher with the use of BIS than it was without BIS, right? Which seems very odd, but can probably be explained by the fact that in the UK and Ireland, BIS wasn't used in all patients, and it was probably being used more selectively in patients that they perceived to be at higher risk of awareness.
Okay.
And obviously didn't prevent it. Well, we don't know if it did or not, but it didn't completely prevent it. Now, what I would say about post-SEG, and people always talk about BIS, but remember, it's not just BIS. There's lots of different monitors available. It's just like calling tape, sellotape, or a vacuum cleaner or a Hoover. But anyway, they can be. I think they are very, very useful monitors. Actually, I think that they're a very useful adjunct monitor. They're completely harmless. They're non-invasive. They don't do the patient any harm. So it's not like putting in an arterial line or something like that. So they're quite easy to apply. They're safe. And I think they can give you useful extra information, irrespective of whether you're using TIVA or inhalational anesthesia. I don't think that they're essential if you're using intravenous anesthesia. Where they would be more strongly recommended would be in patients who may be at higher risk of awareness. Now, these are where you're going to paralyze patients. If you've got a patient who's difficult to anesthetize, you've got a history of awareness, obesity, things like this, where it's difficult to titrate drugs, then I think it could be even more useful, let's say. And certainly in the Society for Intravenous Anaesthesia in the UK, they do recommend, if you're using TIVA in patients who are paralyzed, then you should use processed EEG. And I think that's a fair thing, but I don't always do so, to be honest. But no harm. And
clinical
again,
signs are just as good.
Well, clinical signs are fine, are absolutely fine if the patient's not paralyzed, because an awake patient's not going to lie there, and let you do surgery on them. So obviously they're going to move and things like that. The other thing is, if you do use EEG, then I would recommend having a look, at the articles and so on the internet, even have a look at our review, and just spend a little bit of time to learn how to interpret the raw EEG signal, because actually I do think that is much more important than this sort of number-based technique.
Okay, very good. Thank you. Let's move on to one part of your slide that's very important about TCI limitations. We have much more, the population is no longer as it used to be. We have a lot of geriatric patients. Somebody in the Q&A box mentioned bariatric surgery, so obese patient. I understand that you mentioned this Eleveld model with Mindray, which is very new, and we still don't have it yet. So on your daily practice without this model, how do you adjust your TCI settings for these special populations?
Yeah, that's a very good question as well, actually, and I do appreciate that you guys do have quite a bit more experience with that than I personally do. I haven't. We don't have so many obese patients here in the sort of Chinese population, but we do get them, and I do use TIVA. So it's quite a little bit complicated to explain how to do it in a short time. But if you think about patients with obesity, now in the past it was quite difficult because the models are not very good. The Schneider model has what's called allometric scaling, which was supposedly able to be used in obese patients. But you'll find that there are big problems with it because it uses a thing called the James formula, and it's really not reliable at all, particularly as patients get the BMI goes up and up. So I still tend to use the Marsh model, and to simplify it, if you're just using the Marsh, what I did was I would see what the patient's actual body weight is. I would calculate what their normal body weight or sort of ideal body weight would be. So let's say I had a patient with an actual body weight of 120 kilograms and the ideal body weight was 80, then I would calculate the difference, which is 40, and I would divide it by 3 and add that third onto the ideal body weight. So you're going to be something like 95, something like this. And the reason for that is because the fat itself doesn't take up a lot of the drug, right? But muscle does. And obese patients are actually not just fat. People think, oh, they're just extra body weight, it's just fat. But actually, you need quite a lot of muscle to carry around all that fat. So they actually have quite a lot of extra muscle. And so that's to compensate for that a little bit. So that's what I used to do using the Marsh. And I think very careful titration. Now with the Eleveld model, I haven't actually been able to use Eleveld in obesity, but it does have much better allometric scaling. So it seems likely that Eleveld will be useful for that. There's also another model called the Cortinas, which was let's say developed by an anesthetist in Santiago in Chile, and I think that Cortinas model will be available in the Mindray later this year. Maybe they can say, I have a feeling it is. And so there is a specific model for obesity which can be used also. Okay. So that's maybe a long-winded answer, but trying to be as quick as possible.
Okay. What about older people? How do you adjust?
Okay, so I think it's,
geriatric add?
anesthesia for older people, again, is another very special area. I funnily enough, wrote a couple of articles about that too. Last year for Anesthesia Journal, we run a supplement every year. I think it was last year or the year before. It's free download as well, about how to manage anesthesia in these elderly frail patients. It doesn't matter what you're using, whether it's propofol based, inhalational based. These patients will be much more sensitive to to both the primary anesthetic effects of the drug and also unfortunately to the side effects and the adverse effects of the drug. So the key thing here is patience and being gentle. I think actually as I say, I always use TIVA. With my TCI, I start low, 0.5, 0.6, and I'm very patient. I just let the drug concentration rise nice and slowly and nice and slowly. And many times I'll need very low concentrations to maintain anesthesia. Maybe 1.8, 1 micromil is not unusual for an elderly patient with propofol to keep them unconscious. And use adjuvant techniques where you can, use regional techniques where you can. Maintain normal blood pressure, this type of thing. But certainly don't go in with like a 20 ml syringe of propofol and gangbusters. You've got to be very careful and patient.
Okay. You mentioned also earlier about if you use remifentanil as the surgery ends, if we stop it, we should be mindful about the abrupt loss of analgesia there and possibility of hyperalgesia. So how do you try to compensate this?
Okay, so hyperalgesia, there are two problems potentially with short-acting opioids like remifentanil, fentanyl, and the other ones as well. One is hyperalgesia and one is tolerance. Now, I'll just quickly explain to the audience the difference between these. Tolerance is where you require increasing doses of the drug to produce the same effect. Hyperalgesia is where a dose of the drug produces a paradoxical effect. So by even giving this analgesia, you actually make the pain worse. Now, both can be shown experimentally with all opioids actually, and particularly with these. But in the clinical setting, hyperalgesia is very, 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 would be very rare, very unusual, even with using it, for quite long duration, even high-ish doses. Tolerance is more likely, but again, if you're using modest dosing and it's not, excessively long period of time, you're not likely to see clinically important tolerance. So that means, you've got to keep your REMI concentration, about 0.15 to about 0.25 mics per kilogram per minute, or about 3 to 5 nanograms per mil blood concentration. I do that all the time for surgeries, 12-hour surgeries without any problem. The second thing is you can use analgesic adjuncts where possible, particularly ketamine. Ketamine has been shown to reduce the risk of both tolerance and hyperalgesia if it's used along with remifentanil intraoperatively. Also, non-steroidals, COX inhibitors, COXIBs, and so on are important as well. And you can also remember you can use a combination of opioids, so you can use a longer acting opioid intraoperatively to help to reduce your dose requirements for remifentanil. So those are ways. If you do this, these issues will not be a clinical problem. I've written an article about this as well, actually, in Anesthesia.
Okay. When you combine it with ketamine, say, so we would use like very low dose of ketamine.
I don't use a very low dose. Some people do.
Okay.
I mean, I probably use about 0.5 to 1 milligram per kilogram as a bolus. And then my technique for an average patient would be top that up by 10 milligrams every hour, or you can set an infusion, whatever you like. So that's not really low dose. Some people use quite low doses. I use those doses and I don't find a problem. Sometimes patients may look a little bit spaced out and they just wake up but doesn't seem to be any long-term problem. Ketamine's an interesting drug, not just its analgesic and maybe even preventive analgesic effects, but it has now got an indication for the treatment of so-called treatment-resistant depression. So there have been a few studies showing that patients who get ketamine intraoperatively have a better mood scores and less anxiety after surgery as well. So it may have a number of benefits.
Okay, that would be something I would like to try in the near future. There's a question: if we don't have the TCI pumps, and we do you still use regular pumps for?
Well, yes, I personally would, but remember, I've been doing this for over 30 years, so it's not something. I honestly tell you, I wouldn't recommend it if you're a novice. I wouldn't actually. It's not worth the hassle. But if you do have access to EEG monitoring, then you can use manual infusion, and you can titrate it to you can use the standard recipes are used for manual, and you can titrate it against EEG. So that's actually quite safe. But doing it blindly is difficult, to be honest. And I wouldn't sort of, it's not something I'd recommend unless you've got a bit of experience.
Okay. So there is, in the early talks of your presentation, you were talking about how this is in line with ERAS and it reduced costs, but the capital that you need to set up all these TCI pumps and probably monitoring devices can be quite costly. Do you have any experience how to persuade your hospital administrators to go to start TIVA practice?
Yeah, that's a good one as well. Actually, I think you would basically look at the sort of evidence that I've used today, and you can get from other review articles and so on, to show that there appears to be tangible benefits for the patients. I mean, at the moment you're talking about things like you can certainly show there's less pain, you can show there's less nausea and vomiting. That they can have knock-on effects, and there are studies which would show that hospital stay can be reduced with these techniques. But ERAS is a whole concept. It's not just TIVA. There are lots of different things. So there are many different things to consider. So I think what would be a real game changer would be the cancer stuff. If you could show that, and if these prospective studies which are being done do show a benefit, then it would be very difficult not to consider using TIVA. But I would base it. To be honest, I've been very lucky. I haven't had to actually make this recommendation. When we actually did commission a new hospital not long ago, but we were going to need infusion pumps for intraoperative use generally. So we ordered ones with capability for TCI as well. Those pumps, remember, they can be used for all sorts of different infusions, inotropes and all sorts of things. So they're not just for TCI, but they can be used for TCI as well. That's how I would try to pitch it, I think, to look at the tangible benefits. I mean, you can even do, maybe local audit or studies. I remember there was a study some years ago in Scandinavia that looked at day case gynecological surgery, which was very interesting. They compared propofol with isoflurane, which is actually even cheaper and so on, and found that with the propofol, they could get the patients awake more quickly, they could get them out of the recovery room more quickly, but they were all still able to go home the same day of surgery, even though some had more nausea and vomiting and so on, but they could still get them out of the hospital. But the interesting thing was they followed the patients up for a week afterwards, and they found that when they phoned them up, the patients who had the isoflurane took on average 1 day a week, 1 day more off work than the patients had propofol. So there can also be other, the whole issue of healthcare economics is very complicated. It's not just the unit cost of drugs. There's a whole host of things that go around it. And in fact, you can actually even show, if you look at that lecture that was written into Anesthesia and Intensive Care concerning our audit or our survey, showing very clearly that propofol was way cheaper than some of the inhalational drugs. Desferin 10 times more expensive, and sevoflurane is at best comparable, but probably more expensive with the general use.
Okay.
Oh yeah.
All right. So about cancer, which is one of the main reasons why patients are getting ERAS surgery right now. You mentioned in your presentation that the effect is reduced by propofol, but not by other drugs that you use in TCI, like opioids or tibaketamine. Was this effect solely a propofol thing, or is there any other intravenous anesthetic that helps?
Sure. So I did give a talk last week about this, and it may be, if they're recorded, that the audience can go back, and if they haven't heard it, they can look at it, which goes into this in much more detail. The benefits are likely to be propofol mediated benefits. There are other drugs which may have effects. Ketamine appears not to have any kind of adverse effect. It doesn't suppress immunity or anything. It may reduce inflammation a bit. Lidocaine is another drug which has been looked at, but not so extensively. May have some potential benefits, even has been used by oncologists to potentiate effects of their chemotherapeutic drugs. The opioids are a bit controversial because about 10 or 15 years ago, there was a lot of concern that opioids may actually make the cancer recurrence worse, but they were very small, underpowered studies, and the bigger prospective studies like the MASTER trial didn't show any difference. And if you look at the mechanistic issues with opioids, they actually can have some beneficial effects as well as some potential detrimental effects. And opioids, again, have also been used by oncologists to help potentiate effects of some chemotherapeutic drugs. So I think opioids probably, I don't think you need to worry about them. I think you just give them if you need to give them. Don't worry that you shouldn't give them for patients with cancer. I don't think that there's any really good evidence that they have any effect one way or the other. But propofol is definitely the most promising from a basic science perspective, from a retrospective perspective, and hopefully from a prospective ongoing randomized clinical trials.
Okay, because I think from the aforementioned study, it follows patients in quite a long time after the surgery, whereas the propofol was given as a regimen only throughout the surgery.
Yeah, absolutely. This is the fascinating thing, right? I mean, I completely agree. It's literally hard to believe, right? You kind of imagine. I mean, I talked to oncologists about this, obviously, colleagues and so on, who hadn't been aware of this. And it's really difficult to conceive that just giving a drug intraoperatively could have such a profound effect. If it's true, right? We don't know. But then when you think about it, if you think about it, it's a little bit differently. If this is mediated by the ability of something that's given at the time of tumor handling and manipulation, which reduces the ability of circulating tumor cells to actually go into the tissues and start to grow, or set the stage for later metastasis, growing metastasis and secondary tumors, then it kind of could certainly explain, because if you're having an immediate benefit, then that benefit may well be persist or over a period of time. So it's intriguing, but I very honestly couldn't give you a complete answer to that. It's just my thoughts about why that might be the case.
Yeah, but nonetheless, it's still a very promising reason to use propofol for these types of surgery.
I think it is. Yeah.
And perhaps even for sedation in the ICU after the surgery, if the patient.
Yeah, I mean, one of the ways I think about it is, it's not like you're doing something that's potentially harmful to the patient. You know what I mean? It's not like giving a chemotherapeutic drug which could have side effects, but then it may have this benefit that we're not sure about. Then you would be reluctant to use it. But you're giving a drug which you're going to give anyway because it's an anesthetic drug and they need to have anesthesia, and it has other benefits like less nausea, less pain, this type of thing. So, why not use it? And if it does have this benefit, fantastic.
Then
If it doesn't, you haven't done them any harm.
Okay, very good. There are several questions in the question box, which asks about, you mentioned this very interesting case of this Hong Kong businesswoman, and you pepper throughout your presentation the word psychosis and POCD and delirium. Are these three terms the same? And can you identify which patient might be more prone to these effects, and hence we should pick TIVA? What do you think?
Yes, well, to answer the last part first, those patients who are more prone are the what we call more vulnerable brains. So the older a patient is, the more likely it is to develop. If a patient has signs of what's called AMCI, amnestic cognitive impairment, but this is like some of the potential early signs of, maybe I've got it myself actually, because I'm forgetting things. Of developing Alzheimer's or dementia, like the family saying, oh, he's always forgetting things, or he doesn't know where he put the keys, and this and the other. These patients at the extremes of age and that have already some signs of this may be more vulnerable. Patients who have a history of chronic drug use are more likely to develop it, and that doesn't just mean non-prescription drugs. That is things like alcohol, which I guess in the US is not so common, and it's not so common in Hong Kong either. But certainly when I worked in the UK, that was a big thing, and smoking as well. Patients who are smokers and then stopping their nicotine, that they're more likely to develop delirium afterwards as well. So there are certainly some types of patients who are more vulnerable. And then the nomenclature, whether you call it the delirium, psychosis, whatever, they're a little bit interchangeable, I guess. And but they can present quite differently. Actually, the clinical facets may be quite different. Everybody thinks of the delirium psychosis being the patient who's pulling out the IV lines and shouting and bawling in the recovery room, but also those patients who are withdrawn and very quiet. And maybe pulling at things or doing things, but not hyperactive. This is a hypoactive delirium. It's actually much commoner than is often appreciated. So it's important to look out for that as well. So that's that. I think that in terms of prevention, the ability to prevent the acute kind of delirium correlates quite well with the type of anesthesia. So the Propofol probably has a benefit there, but for longer term cognitive decline, then that seems to be much more multimodal and may not depend so much on the type of anesthesia.
Right. On this note, I actually would like to add, there's a study in my university by Dr. Ade and her colleagues. It's on children which underwent anesthesia using our standard regimen, which includes inhalational anesthetics. But at the end of the surgery, prior to emergence, they turn off the inhalational anesthetics and give 0.5 mils per kg of propofol before the patient wake up. And the result is very good. These patients experience less emergence delirium and are less agitated in the recovery room. Yeah.
Yeah, I've heard that. Yeah, I'm not against that at all. Whatever. I don't. It's not something I do myself. I think if I was going to go to the trouble of giving TIVA, then I would just use it the whole way through. I doubt very much it will affect your overall costs. Like maybe the perception is it's cheaper or something. I don't know. Or maybe they don't feel so confident using it for the whole surgery. Or perhaps in that case, maybe it is a reasonable thing to do. And as you say, it seemed to work. So yeah, why not? Yeah.
Yeah, because I think it's one of the bridges, because we are not, the pumps for pediatrics is not widely available in here. So confidence is definitely an issue. I think before we wrap up, there is this one last question from from Penang. Welcome, Dr. Lee, which asks about propofol infusion syndrome. How common is it? Should we be worried? And should we have caution? What do you think?
Fortunately, it's very rare. In fact, it's so rare. I have never personally seen that in my whole entire career in a patient in anesthesia. Now, it can occur obviously with longer infusion in higher doses. It's more common in children. It's more common in children who are being sedated for with neurological illness or neurological disease. It's thought to be due to some propofol effect and mitochondrial effect and abnormal metabolism in the mitochondria as a result of prolonged and high dose infusion of propofol. It may also be related to the lipid that's given. So that's one of the reasons why higher concentration lipid formulations of propofol have been used, for example, in intensive care. But I think and I'm not an intensive care specialist, so I wouldn't go into it, but I think for normal anesthesia, it's not something that you need to worry about.
Okay. Would you use it though on like little children?
Yeah. I don't do neonatal anesthesia. It's a very special area, and we subspecialty area for us. So we wouldn't do it if we're not trained. So I sometimes do children, but not like those neonates. But my colleagues, I have colleagues who use it. Yeah.
What is the youngest age you're more comfortable on using?
I think they're using them in patients of all ages. Several months old and so on. Yeah, no problem.
Okay, thank you very much. It's been a great discussion for us.
Thank you.
I would give this back to Krisha because she's already here making us finish. Thank you very much for the discussion. We learned a lot in the past hour about TIVA TCI, and hopefully this is getting much more popular as more TCI pumps are being available in many hospitals here in Indonesia. We thank you, Professor Erwin, for your time. I will wrap this up and give this back to Krisha.
Okay, cheers. Thanks for the invitation.
I know for moderating the session. Thank you very much. I would like to thank Mindray as well for sponsoring the session. Again, thank you so much, Professor Erwin, for the second time. I believe last week, right?
Yeah, that's right. Yeah. Thanks, Risa.
Yeah, thank you very much.
Conference. Okay, cheers. Bye, Eddie. Bye. Thanks.
Thank you.
Bye.
Okay, so we finished industrial sessions. We're going to move on to the next session.
Nowadays, more and more clinicians may find it difficult